So welcome to another episode of the Osteopathic Lyceum podcast. Today we have Dr. Sandra Monteiro joining us. We're going to talk about a few topics. First, I will say that I had the absolute pleasure of being your graduate student, so you were my thesis supervisor. And instead of me messing stuff up and providing biographical information, I'll let you just say a few things about your academic background that you think are pertinent. And you don't have to be exhaustive because that often bothers me when I listen to that.
Yes, I will be specific and relevant to this conversation. So I'm very happy to be invited to have this conversation with you, Sam. And we've been friends really since I agreed to supervise your thesis work. Definitely learned a lot from you at the time as well, and still do. So, and I'm glad you're taking your learning off into the world. So yes, doctor by means of a PhD, not a medical license, just to clarify. Don't come to me for any kind of life-saving help. And my PhD is in cognitive psychology, which means that I understand memory, attention, and just learning principles, basically, and how that happens. So I apply that as an education scientist at McMaster and do my best to try to improve the education we design locally and internationally, hopefully.
You mostly seem to focus on clinical decision making as it stands. Is that fair in most of the research that you're working on?
Yes, although I do, not to be like that annoying person who corrects your grammar or something, but I don't think it's a small point. My experimental work, like empirical studies, have looked at diagnostic accuracy, so maybe diagnostic reasoning. And that's a very niche area within a broad, like clinical reasoning focus that people have been interested in for years and years and years. The reason they're interested in that is because the expert seemingly does things through magic. And because because it all happens in the mind, you can't actually see where two and two are being put together and where insights are coming from. And so because you mentioned clinical decision making, that's a little bit different the way that I define it than diagnosis. For me, decision making is an involved process where you know the goal. You need to decide on a set of actions. And in making that decision, you have some costs and benefits to weigh and risks and such. And so that can also happen in a very magical way in that experts are really quick to make decisions. They're really quick to make a diagnosis, and they're usually right. I just think that underlying that is a different process.
Yep. Well, I appreciate the fact that you actually provide more accuracy. It's actually something that my daughter complained about not that long ago with me. So she was like, "Oh, does my dad do this to you too?" And the person she was talking to said yes. And she's like, I do it too. So the accuracy is important. And also just on the point of those who seem to be faster to a diagnostic decision, they are usually more accurate. And it usually, there's a paper that I remember, I think it was 2014 from, I think Dr. Sherbino was the lead on that paper. And it seemed as though basically the faster you made the diagnostic choice or the diagnostic chose a diagnosis, that you were more accurate, and that was indicative of having more knowledge, which would suggest that expertise is more an arc of accumulating experiences and details. So you've done a bunch of steps for a very long time, such that when you observe me, it looks fast, but it's been decades or something like that. That's why when you jokingly say it's magic, I'm like, it's not magic. They just did a lot of stuff and made a lot of mistakes.
Yes, no, exactly. And so like it's, in terms of the diagnosis, it's assigning a label to what you see, right? We do that every day. We assign a label to furniture, table, chair. Those kinds of, it's the same process underlying that when clinicians look at a diagnosis or look at a patient or a set of symptoms or complaints, then assigning a label to it can facilitate the plan that needs to come after that, whether there's a drug or whatever treatment or conversation they need to have with that person. And so in terms of drawing on my knowledge from psychology, it's a lot like research done on categorization. So how do we, as humans, from a very young age, learn to categorize the world around us? And yes, just as you said, experts get there by just making many, many mistakes and figuring it out along the way.
And they have to know that they made the mistake, otherwise they don't learn anything.
Yes, that is often a missing component in a lot of medical specialties. So they can't learn in that way.
Yeah. Well, it's interesting to me because not necessarily the intended finding of my experiment, but the finding that was primary was that if somebody knows they made a mistake, then they would correct it. But usually they don't know they made the mistake. So somebody else tells them they made the mistake and they correct it. So it's the acknowledgement that there was an error. If that happens, learning seems quick.
Yes, and that's so in terms of the studies that you were referring to with like speed and accuracy, psychology and probably kinesiology, like it's been known for decades that if you're an expert, your speed goes up and your accuracy doesn't suffer. But for most people doing tasks, they've just learned if you make them go faster, they're just going to make more errors because it's not as fluent for them. When it comes to diagnosis, one of the reasons that we'd conducted that experiment was to just test this theory that was out there, this recommendation that people should, medical doctors should slow down, think about the problem more, and that would increase their accuracy. And so just as you noted, what we found was slowing down didn't help. If anything, in the one study, we found like it kind of broke even in the sense that sometimes they changed their mind to a correct answer, and actually sometimes they changed their mind to a wrong answer because they had more time to reflect on it. The missing piece was we weren't telling them what was wrong or correct, or we weren't guiding them to look at something else differently. So based on just their own perception of things, they couldn't find the error and they didn't know in which direction to correct. And then in other studies, we have shown that the faster people, when asked to diagnose some cases, the faster people tended to be more accurate. They just, you can go fast when you know more. And so in that case, speed and accuracy were, I guess it would be negatively related, like the faster the speed, the higher the accuracy.
The initial impetus for looking at it that way was in relation to that kind of system 1, system 2, thinking fast, thinking slow, heuristic based, slow reasoning based, that mostly came out of Daniel Kahneman and Amos Tversky's work, such that had come into the medical field, and they were trying to utilize a lot of cognitive debiasing, cognitive forcing strategies, and it was having no effect.
Correct.
It was having no effect specifically on reduction in medical error.
Well, and I think in terms of that story, that absolutely right. I think our group, and at the time, when you refer to any studies in 2014 or 2012, I was still a graduate student myself, but working with a group, we were probably the first to try to test that theory and see if those strategies worked. So up until then, they were making recommendations with no evidence. So, because they're, so the thing that psychology does poorly as a field is to just put a lot of information out there and not necessarily weigh the evidence against other fields, and we work in silos as psychologists. So I'm doing my thing over here, looking at decision making. Someone else is doing their thing over there, looking at how memory works and how categorization works. And what most people don't appreciate, unless they are in psychology and have trained and suffered from having to learn how to create an experiment in that field, their paradigms are very different. So from the beginning, people that were interested in decision-making, reasoning, and problem solving decided that they actually didn't care about the knowledge you have. And so your expertise was irrelevant to their curiosity,
Mhm.
but the problem solving process. Like, how did you take information you were given and put it together to come up with a solution?
Mhm.
And so they created very artificial problems
Yep.
that they could guarantee had nothing to do with your career or training or anything like that. And made conclusions based on how easy it was to trick people into
Yep.
coming up with the wrong answer, or
Yep.
or coming up with very algorithmic explanations for how people used the information they were given.
Mhm.
And there are people who have explored those same questions differently, and they've
Mhm.
actually looked at experts versus novices. And then you do see
Yeah.
that it matters. It
Yes.
matters.
Well, that's actually what I was going to say as you were walking along that line or walking along that path. I'm like, well, you were just examining novices, so of course they look like
Yeah,
poor performers.
right.
Now, is it fair to categorize those initial groups that were doing those experiments as behaviorists or behavioral psych?
With the decision making,
Yes. Is that fair or unfair?
I think it's unfair. I think they
Okay.
actually would be called cognitive
Okay.
psychologists,
Okay.
where because it's about the hidden processes in the
Okay.
mind, right?
Okay.
The behaviors that might follow from that are
Mhm.
maybe of interest, but the initial starting point is, how does the brain put this information together?
Sure. Okay. And that's positive for me because I have what I consider an accidental preference for cognitive psychology. Like I wasn't expecting that in any way. It's mostly because what I at the moment with the amount of information that I have view behavioral psychology used for right now is
Right.
mostly for attempting to manipulate groups of people,
Sure.
right? So advertisers and governments. Now, I may be wrong about that, and I'm admitting that I'm missing a lot of information, and I'm also admitting a preference that I prefer cognitive psychology, especially when well done.
Yes. Yeah.
And
Clearly,
then,
I do as well. So we share that.
yeah, well, a part of me is building an understanding that a lot of my preference might be accidental in relation to the fact that you were my supervisor, right? Not that you weren't influencing me. That's not in any way fair to suggest. It's just that the stuff that I was considering, the stuff that I was interested in, uh, I didn't understand that cognitive psychology and behavioral psychology or other branches really were different in any way, and I was concerned about learning, right? Or especially the behavior of an instructor with respect to learning outcomes or performance outcomes. And it wouldn't have crossed my mind, not knowing anything about cognitive psychology. Well, that's cognitive psychology.
Yes, it seems like you had the interest and the knowledge and the curiosity that's relevant to being a cognitive psychologist. You just didn't have that framework
Yeah.
yet, or like the theories. So,
Mhm.
yeah.
So, which brings me to a question that I'd like to pose
Mhm.
with respect to is there an overarching set of concepts that would best describe fundamental learning mechanisms? And I'll couch this in that I know that you're not a large fan of things such as adult learning theory, right? Or the department that I have been associated with is very fond of noting that things like learning styles are kind of ridiculous,
Correct.
right? Or at least the research that went into the claims that are made that people associate with the term learning style, such as audio, visual, and whatnot. It doesn't mean that there isn't learning styles necessarily. It's just that field is kind of messed up. So that said, are there things that you can note that would be considered fundamental learning mechanisms that would span across a life?
Okay. Sorry, I feel like that was a test. So let me just take a moment.
I didn't mean it.
You're now quizzing me. I think so. I will preface this with saying that it is difficult to find a principle that generalizes across
Yep.
the lifespan or even groups of people.
Okay.
But they're sure, drawing on research about memory and attention and perception and those kinds of basic learning principles, then having some familiarity with the material actually is the best way to learn.
Okay.
Sounds backwards, but when we encounter information, if there's already, if you think about it as like you've got a warehouse of like, and
Mhm.
shelves and racks and things for
Yep.
things for information to go into. When you encounter new information, if there's already a little like box where it can fit, then it's more easily absorbed, it's more easily accepted, and you can more easily make associations.
Okay.
So that, like I said, that sounds backwards because it's sort of like, well, how do you get the knowledge before you get the knowledge?
Yeah.
So that's where people come up with strategies like scaffolding, right? And so you kind of break the learner into the context, you give them some sense of like what the environment might be like. And I'm thinking clinically, right? You can introduce them to like, what does it look like to be in a hospital? And then work them up to what does it feel like to talk to a patient, right? So they can start to experience any emotional challenges that come with that.
Yes.
And then over time, you're basically creating that scaffold, the literal racks and things in the warehouse. And then you can start to put in the critical knowledge. Yeah.
Now, as an analogy, would that also relate fairly well to a semantic network or the concept of a semantic network?
Yes. So yeah, absolutely.
I was going to say, so the scaffolding may be a good way to describe how you would build it, but the semantic network is maybe the phenomenon that you're trying to engage.
Yes. So in terms of how the brain collects and uses processes and understands information, the current theory is that there are associations created. And so semantic network is one way to describe associations based on the meaning of things. Most memory researchers will subscribe to a theory of just just that associations. Anything that you know now or think of in the past could be associated. We use the word similarity or familiarity like it means something concrete, but we don't actually have a way to measure it. But that is the only mechanism that we can point to that suggests, two things will now get associated because they were familiar or similar to each other.
Sure.
That's so having some meaning to the thing you're learning. Sometimes that meaning can be self-created because you're really motivated.
Yep. Oh, yeah. Well, at the point that you're looking at what I would call highly self-sorted groups or self-selected groups, such as medical students or people interested in any healthcare field or somebody pursuing astrophysics, right? Studying those groups for pedagogical reasons may not be the right groups. Like, it doesn't mean that there's nothing there. It just means that I believe Dr. Norman points this out a lot. It's like the thing that you can't control is the keen student who goes home. Like you're utilizing a university level student for your research, and you do one piece of it, then you send them for a washout period. Well, they go home and study.
Sure. Yes.
Right. So it can affect your result because they've gone and learned on purpose. So this brings me to the concept that I found very interesting in thinking about after I defended my thesis, that I came to the concept that I think instructors often overestimate their impact. Right. So I think as far as say performance is concerned, that what I think the key is to driving performance is the availability of the required information or the required skill. Such that the impact of the professor is really only going to be noticed when they don't provide the required information.
Right.
So, and now if I remember correctly, you had noted that, or maybe I heard this somewhere else and I'm conflating things, but if you look at, say, one course within a university and there's multiple instructors and you look at the outcome data or you look at the testing data, all you really tend to see is that smart students do well. You don't necessarily see the impact of the instructor.
Yes. So studies that have been done along those lines show that the instructor impacts learning 2 to 5% overall of the available, and the student is like the 90%, right? So the way the curriculum's designed might fill in the rest, but the instructor themselves and the way they lead the class and the curriculum design is still a very small piece of this, but it's what the student brings to the exercise.
Yeah, and I've heard that in different places, that the primary predictor of student success is the student themselves. The primary predictor of that generally happens to be the home that they come from. So the higher level of education in the home itself, and then often the more income in the home seems to have a generally positive impact.
Yeah. I mean, it
And
makes sense. There's access to resources, tutoring,
yeah,
like even just buying books early
yeah,
on and having the time to read together early on,
yeah,
like that foundation for communicating through reading and writing.
yeah. Well, the
Yeah.
thing that I heard that I found very interesting was that it seems that the concept of birth order effects really is more about attention, right? So the
Hmm.
oldest child ends up accidentally having the opportunity to have more attention, whereas in circumstances where you would have more economic activity in the home or more income in the home, the parents or somebody else may have the opportunity to pay attention to all of the children.
Oh, okay. I don't know anything about birth order effects
Yeah.
really, but
Well,
that
I've
sounds.
heard about it, and you hear in colloquial conversations or people like, "Oh, you're a middle child," like stuff like that.
There's definitely a lot of societal anecdotal beliefs around like that ranking and that impact on personality and
Yes.
performance and all of those things. Like I said, I don't know
Yeah.
how easy it is to actually capture evidence of that kind.
Yeah.
But
I would think it's hard, but and such that when they do it, there's probably mistakes in it. So the stuff, the paradigm that they're working under constrains what the conclusions would be, as well as the question.
yeah.
But the thing that I've seen as somebody that I don't remember exactly where I identified it, but was just saying the primary difference seems to be attention available.
That's possible. Yeah.
Yeah. So and I appreciate you noting. It's like, well, I haven't looked at it, so like I don't know what to do with this.
You're not going to force me into being more concrete on that.
No. Well, and that's something I greatly appreciate. Something that I don't know that I did when I was younger, but I've done in an obvious way since having my or attaining my master's or going through that process is I appreciate uncertainty much more.
Right. Yeah.
I really appreciate it. If somebody's very, very confident in their answer, I get concerned very fast.
And what's funny though is like, and a lot of more expert clinicians, right, in
Mhm,
any specialty or profession, they have that same experience. They
mhm.
appreciate uncertainty. They get that comfort with it.
Yeah.
What I find really odd is that some people conclude, therefore, we should make people comfortable with uncertainty from day one.
Mhm.
Can't imagine how you would do that without them living through all the mistakes they've made and
Yes.
seeing like how, small things can make a difference.
Mhm.
And they earn that comfort with
Yeah.
uncertainty.
Yeah. Well, I think a conversation that you and I have had is that what I would classify as the say cardinal mistake of a novice is not a mistake of observation, it's a mistake of interpretation.
Mhm.
They observe everything, they believe that they're not able to interpret it appropriately, and maybe they aren't, but that's where they make their mistake, it's
Yeah.
interpretation. Whereas the expert would often be the sin of omission.
Yeah.
There's along the way from novice to expertise, you learn what to omit most of the time, what means something. So it seems as though, in what I understand, experts will often pay attention to far less cues because they kind of hone in on the cues that they've learned that are important,
Yeah.
right? So
Yeah.
it's actually one of the reasons, it's that concept that seems to have done something for me, which drives how I suggest in my profession of osteopathy how people should diagnose things. So if the sin of the novice's interpretation, then provide them with a framework in which they can assess things, that it will be less cognitively demanding. So to decrease cognitive load, make things
Mm.
way more simple, give them less things to interpret, right? So minimize the amount of tests that they do, but make it procedural so that they have to go step by step through it, such that the expert won't miss those steps. So I've created something or put forth a framework that I think has value, that it is kind of able to encapsulate.
That there's no truth. And so
Yeah,
truth is created by any one person. To me, that's like the same thing as saying there's one truth, but each person lives it differently. And
Yep.
so will be variable in
Yeah.
how
Well,
they reveal the truth.
the
But
thing that becomes challenging at that point is when somebody begins from that position, it's not possible to have a conversation with them that goes anywhere.
yeah,
Right? They've limited that possibility. So I this is maybe tangential, but you see there seems to be evidence that suggests that sort of worldviews and where you may fall out on a political spectrum relates to not necessarily affect, but clinical states, right? So what you tend to see very, very, very roughly and very broadly is the left of the political spectrum tends to contain more people who are depressed, where the right tends to contain more people who are happy, right?
okay.
So, and I would very, very broadly suggest that the further you go left, the more likely, not definitely, but the more likely you are to drifting towards something along the lines of a graduated system or a graduated licensing system. And something that we talked about offline was that we probably already have something like this very, very roughly in PGY1, PGY2, at least in the North American context. Other countries, not so much, but there is a progression. It's just that maybe isn't looked at. You hit this summative exam for licensing, you pass it or you fail, and then you just kind of keep going. But within that article, there was the note that the summative exams or the licensing exams don't necessarily seem to have any impact on things like medical error or lawsuits, or they don't really have predictive value there.
A standardized, structured, high stakes, one-time kind of licensing exam. I haven't seen that data speak to performance assessments. So performance assessments, some people might know as a OSCE, or so it's a structured exam. Everyone kind of has the same scenarios they might work through. And then they're assessed on that performative skill. They might be required to take a physical assessment. They might be required to have recommend treatment, or any number of things. And it's a timed interaction with a trained actor. So OSCEs in that sense are used in some licensing exams by some professions. Most of the data, the only data that I'm aware of, has looked at the relationship between like MCQ or written format exams and those outcomes down the line. There is good reason for that with written exams or written questions, with questions that you need to read and then write a response to or select an option. You can just fit many, many more of them in an hour of testing time, or even 3 hours. But with an OSCE, you can probably only have them see like 10 patients in like half a day. So that's like basically 10 items, really. But with the other formats, you can just have like a lot of content coverage being measured.
Would it be, so first, with written questions and what you're able to note with respect to some predictive power for later on in a career with things like lawsuits and errors and whatnot, is it possible to relate that to being able to perform better on a standardized test would suggest a higher level of expertise at that point?
Yeah.
Okay. And maybe the wording isn't perfect, but just conceptually, it's like, well, they did better on the test. So at the point of launching into essentially an unsupervised career, they're at a higher level of expertise. Therefore, they're starting from a different point. Or starting differently from that point of measurement. Now, just as a general note, if I remember right, multiple choice questions with respect to reliability and validity tend to perform better.
That's correct. Yes. Again, because you can fit many, many more of them into a given time frame. So you're taking more measurements. But before I totally anger some of your listeners, I will offer a little caveat, and something that a perspective that I also uphold in terms of people that are atypical, or people for which testing is just not a thing that they can work well with. And it's a relatively small group of trainees.
Yeah.
But most of the clinicians that I speak to know at least 5 of those that they've worked with in the past year, where a formal testing environment is just horrible for them and they do
Yeah.
poorly.
Yeah.
But they're the people they would trust in the clinical environment, right?
Yeah. Yes.
Like it's also the case that there are people who do badly in both settings, and
And they're
then
bad.
that's a special situation. But it is
Well,
true
then,
that there are some people for which, like the way the question is worded,
yes.
like because it has to be so constrained, and maybe that's their strength, is they can actually appreciate all the diversity and complexity of the domain or the problem space, that the written question forces them to like think in a way that they just can't. Anyways, point being, there's a small group of people in all of that data for which this is not true at all.
Yeah.
I guess it's just a matter of like, how do you track that? Because they are a small number of people within that setting.
I would assume that when you're able to retrospectively look at the data, they pop out pretty quick, right? So you'd probably see, if you had, say, something like what ideally would be occurring right now, you have some form of knowledge-based tests, you'd see them underperforming. But then when you look at things such as, say, mini CEX, right? So many clinical exams where you look at residency competency committees, they'd look really good in clinic, but they would not compare to themselves well on a knowledge-based test.
And I think that it's exactly what you said. I think if you were to look at the studies that I mentioned before, they're usually correlation studies. So looking at how scores correlate to frequencies of complaints and that kind of thing, it's fairly easy to set up. It would be the small number of people where their scores are low, but when you look at their clinical complaints, it is also low.
Yes.
And then that's the group you pull out and you interview, I guess.
Well, I think the broadly interesting thing for me from that is that depending on the question you're trying to answer, you need different types of data, right? So as you know, if you want to see relationships of test scores to incidences, it's fairly anonymous. It doesn't necessarily note the interaction, the diagnostic accuracy. It just says, how many times did you get sued? Right? And again, fairly anonymized. Whereas when you're looking at practical assessment data, it becomes a little bit more obvious who's good and who's not good at the practical side. And I would think that you'd want to optimize for those practical assessments. While, maybe they get sued less, but really what you're doing with the knowledge test, as far as I'm going to construct it at the moment, is you're testing expertise, right? But in a constrained way. So.
Yeah, a frustration that I've just coming to appreciate. I mean, I've always known this, but the problem is we do not have a good definition for what an expert clinician is, right? Like what skills, what personality traits, what are you looking for that could be the standard we set them against? There's just a general sense of, are you safe right now?
Yes.
Yeah.
Well, I think within a profession where there could be possible bodily harm, you want to set a floor. Like a floor is more important than a ceiling. It's like you're not completely cross-eyed with, major tremors.
Right. And trying to be a surgeon like that.
Yes.
Doesn't seem like a good fit. Yeah.
No. You may be a great diagnostician, but we probably shouldn't let you cut people. Right. So there are realities there. I think a floor is more important. The other thing is that what I would actually think that would apply well would be something such as you'd see in evolutionary biology, you actually want a variety of difference, like actual difference. Now, if you're talking about, say, a healthcare profession, you want a difference of opinion, you want a difference of practice style, you want a difference of approach within the profession, because essentially what ends up happening there is if you try to generate homogeneity within approach, within thought, within anything, then whatever mistake is in that or whatever oversight is in that can't get caught. You want a lot of variation. So there may actually, and also I think we've talked about this previously, where you don't want to build an expert necessarily. You want to build a novice. and then the expert appears over time, as we've already sort of pointed to in this conversation.
Yeah, I mean, at least in those in the component of training where you have access to the curriculum and you have some control over how they spend the time, and there's a bit more of a constraint around the knowledge that they're gaining. Yes, ideally, you set a good foundation so that they can keep learning. And medicine, this is particularly true, the knowledge they need just keeps changing. New diseases, new like resource constraints, whatever. They've always got to adapt in that way.
Or I would suggest maybe better categorization of disease. Not necessarily new diseases, maybe sometimes, or mutation of something, but just a better categorization. It's like, oh, we got a little bit more accurate, so we're a little bit better at targeting.
That's fair. Yes. And well, also new medicine, right? So something that may have been untreatable or maybe is now, and just knowing those options. So they do have to keep learning. There's not a point where it's like, okay, you're done. You know everything that medicine has to offer, and you can just practice it. So
Fair enough. So to point back in the general direction that I was trying to go while I went off on tangents as well, the concept of a graduated process, right? So you're not necessarily against, say, a standardized, or the position of the paper isn't necessarily against a standardized knowledge test, but subsequent maybe to that, you'd be looking at some form of competency-based graduated system. Now, because I don't necessarily have a pointed question, because I think I'm putting this into a broad space, what might that end up sort of looking like, or what might be the aspiration of that?
Yes. Sorry, I did, just to finish a previous thought, which was the small group of people in those correlation studies who do well in the exam, but then also have a lot of complaints against them. So that is the fear of most regulators, right? The people they have backed, they've given them the stamp of approval to go off and practice independently, can do great harm to patients because there's something they're missing, and it's not knowledge. And it's not the stuff that we're measuring through these standardized assessments. So you do need really rigorous, valid, fair methods to observe them in real clinical practice, see how they interact with real patients, see how they interact with real staff and, other health professionals. People can stand them generally if people want to be on their team. So those are also things that can be blended into graduated licensing, where they're demonstrating these things constantly throughout. In terms of the ideal or how that would be actualized, it's very much a systems issue, because you need someone collecting data constantly or semi-constantly. You need them to be trained to collect the right kind of data, and you need somewhere to put the data. Because
and protect it.
It should not be on a Post-it note that is stuck on the side of a computer.
Fair enough.
Or a notepad of like a checklist on a notepad that they just fill out and then add to a pile that falls off into the garbage. We have the technology to do this. So we need the infrastructure to allow these observations to be documented, strengths to be noted, learning gaps or other things to be identified as well. And also, the trainee has to be part of this, where they're setting goals, identifying their own gaps and needs, right? And then it's just a conversation about where they want to go, what other people think of them, how they're performing compared to their peers, and how they're expected to be performing at that level. And then just tracking all of that, but actually having the data that you can examine. What's happening right now, unfortunately, is very much what was happening decades ago, when it was assumed that a single resident could learn quite efficiently and effectively by observing one supervisor, one expert that they're attending, let's say. or even if it was a small class of 5 following someone around, that's still fairly manageable.
Yep.
And the only thing that mattered was the information in that expert's mind as to
Yep.
who was doing well and where their ranking
Yeah.
was, right? Justifying their decision to pass someone or not pass someone or kick them out
Yep.
probably wasn't a concern to most people because that person's the expert and
Sure.
they just got together in a room and discussed those issues.
Sure.
We never really updated that system as technology actually grew and improved and gave us the means to do so. We didn't create the infrastructure nor the culture where it was expected that you document a lot of these observations. And so one issue right now is just even a fear of doing so, because trainees get to evaluate their faculty and faculty get to evaluate their trainees, and then they're
Nobody
both
wants to
afraid
lose
of
a
each
job.
other.
Or nobody wants a lawsuit or to lose a job.
Well, yes, the law profession has maybe benefited greatly from legal issues, and it's not just from patients' complaints. It's fairness in the workplace, and those are serious matters,
Absolutely.
as well. But that definitely interferes with the ability to be objective sometimes. Yeah.
So very broadly, what this generally would look like is you get to a certain point, you're considered, say, level 1. Level 1 would have a generally assigned set of competencies that they already are proven to have. So we can trust this person to do these things. And then what we're trying to do is provide them with information that will make sure that they improve those skills, plus get to whatever the level 2 skills are. And then we're recording that all along. Anytime we're able to identify that maybe there's a deficiency, we provide them with some feedback, and then you're just trying to move them to level 2. So you're more so trying to develop competencies and help them succeed than to make them fail, as a concept.
Yeah.
Right. Now, obviously, there's some circumstances in which you run into failure to fail. So it's like, well, I guess they look okay, and then they get bumped along, and that becomes another problem. But broadly speaking, it seems as though what the group that you're working with is trying to look towards is improving success. So, skill appropriate tasks, skill appropriate unsupervised activities, and then build and build and build. And then once we have an accumulation of data that suggests that you've hit the level of competencies that are appropriate, we move you on, or we allow movement forwards.
And so I'll add to that analogy from before of like scaffolding and this idea of like having a warehouse of places to put knowledge. You'd have to have some sense, and I don't think we do yet. You'd have to have some sense of what that scaffolding looks like for a year 1, right? Like, and we've attempted to do that in medicine with entrustable professional activities. Some idea of complex activities they should be trusted to do at this point in their training. And if they can demonstrate that, then they get to move on and build on it. I don't know that it's always clear that more advanced activities, EPAs, necessarily build on the ones before. Like, I don't know how clear that linkage is sometimes. And I think trainees and faculty kind of get confused about the point of these early set of EPAs and then the more advanced ones. So we could do better, I think, working towards this ideal. We could do better at actually integrating that concept of the scaffold and building associations. You'd mentioned earlier in the conversation about what the instructor might fail to do. So they may appreciate that their job is to give knowledge to a learner or allow them to observe a skill and learn from them. But I definitely agree that some educators overestimate the impact of a single observation or a single lecture where they're sharing knowledge. And I think if we kind of use that analogy of building the scaffold and putting things in places, it would be like that one observation might put like the smallest block into that space, whereas you're actually trying to create something quite large to represent that knowledge or that expertise or that skill. one observation or one time telling them something in a lecture is just a tiny piece of it.
Yes.
I think another way to maybe look at that is if you were running a warehouse and you had some kind of a plan of where everything was kept. The map to where something is very clear in an expert. And so even if that information is there out in the warehouse, the novice has no idea how to find it. They don't have a map, a blueprint. They don't have any kind of coding system. And so you need to show it to them or tell it to them or have them experience and use that information. And so there's a lot of power to be gained by having them try to use the information, right? So if all you can do is tell it to them once, and get them to try to put it into practice, because that means they have to go into the warehouse and find it and use it over and over again. And then they'll make their own map in that way. But I think just time and misunderstanding for how those associations are strengthened does not create that effective space. But going towards the graduated licensing, we can use a similar analogy. Is like, if you're expecting them to learn in this accumulative way, then assess them at some expected points of they've accumulated this much knowledge, right? And they can keep building on it. And the current culture has this 1 day assessment that's very expensive and tries to cover all of medicine, and trusting that people who do well on those assessments will do well later in life. But it's not fair. And it doesn't recognize the strengths they have in the workplace, doesn't recognize their specialization, because it's just a very big general knowledge assessment. So again, the really, really strong students will do well. They're not necessarily the best doctors.
The best actual practicing clinicians.
And then it's not fair to the people who actually do well. They just don't know everything about medicine and they may not need to.
No. Well, it's one of the things that I say so there's a long time criticism in varying complementary and alternative health practices where they look at older curriculum and they talk about contact hours and, doctors only get 4 hours on nutrition. I'm like, what does an orthopod need more nutrition for? Like, a hip specialist doesn't need to know what you're eating. Like, I mean, in the grander scheme, yes, they do as humans. However, their job is cutting your hip. I want them to know everything. I want them to know all the techniques. I want them to know the Western resurfacing. I want them to know all those. Right? I want them to maybe even create a new one, just not on me. But would it be broadly fair that what you're advocating for is just more proof?
Yes. Right now, the proof is in the minds of the people they've worked with, and it's very it should be trusted, but people don't trust it because they think it's subjective. But if you actually wrote it down, that might give it more credence. And if more people wrote the same things down, then that's proof. And so actually documenting the proof and reviewing the proof and learning from the proof.
The thing that I count myself lucky for is that in my profession, the actual competencies that I would claim are required are much smaller and much more simple. So I think they're much easier, at least with the hands-on aspect, not necessarily for a doctor of osteopathy from the States. They have unlimited medical licenses. Let's be much more rigorous. Well, not to say that what I would want to do would be less rigorous, but to say that the competencies themselves are easier to identify and easier to scaffold, because it's, at least in my particular case, I've put forth a set of heuristics that would guide all of the things that you would have to do and all of the decisions you would have to make in fairly simple ways. So I'm just trying to reduce cognitive load all the time. And then your solutions are relatively straightforward. And if it didn't work, well, you have a bunch of other ones that you can generate really quickly. But the repetition is of obvious value. So if I provide a heuristic such as with respect to how you would choose to position a patient for a particular thing, because I would use multiple positions for patients in relation to a table, right? So the quickest one that I can provide is the table makes stable, which is explained as the more of the patient that is in contact with the table, the more stable they are and the less uncontrolled and unsafe movement happens. So
Yeah.
you start there. And then what I can do to build that as a like as a piece of the scaffold, as a rod or as a cross beam is, okay, I want you to position the patient so that it's very easy to treat their neck and so that they don't have to control it themselves. How would you do that? Right. And then people would
Yeah.
make a choice and I would say, okay, interesting choice. How about this one? Right. So it's got a lot of feedback mechanisms built
Yes.
into it because there's a very clear piece of the scaffolding that I can go to and I can repeat and I can repeat, and then I can change it in multiple ways whereby I would use the same heuristic for lots of problems. And then I can provide them feedback and then they can test it ad nauseum. So then I give them the opportunity to have a framework to make a mistake against so that I can provide corrective feedback and they have something to correct against.
Yeah.
Yeah. So it seems like I might have learned something smart.
Well, I mean, we covered all those concepts in the past hour, like learning from mistakes and like building on what you already know, and repetition in terms of going back in and out of that warehouse to use the knowledge. And then at some point they will gain their confidence too, that they actually do know things. And even if a patient walks in that you've never talked about in your class, like they're presenting some issues, they can try to figure it out by putting it all together.
Yes. Yeah, this is why I value the health science education program at McMaster and what I gained from it as much as I do, right?
Yeah.
Like
That's great.
so it's not fair for me to say like I learned so much in this hour. It's like no, I had a long time. Did a lot of work.
Yes, you did. You definitely did. You devoured a lot of literature in that time doing your master's. Yeah.
Okay, so I know that you have another meeting coming up shortly. So what I'm going to do is say thank you very much for the conversation. I'm going to stop the recording, but stick around for a couple seconds so I can properly say goodbye. So thank you very much.
Yes, my pleasure. Thanks, Sam.